Good morning. First of all, I wish to thank all colleagues and organizers from the meeting in order to give me the opportunity to share my experience with that of our Asian colleagues. These are my disclosures. Hepatocellular carcinoma has an increasing incidence worldwide and is the leading cause of death in patients with cirrhosis. It is the fifth most common cancer and the second most common cause of cancer-related death. The natural history of hepatocellular carcinoma is extremely severe, as confirmed by mortality rates overlapping the incidence of the tumor, and we have at least 1 million deaths globally every year. In addition, it is extremely heterogeneous due to the complex interplay between the biological characteristic of the tumor and the frequent presence of an underlying chronic liver disease, as shown by recent meta-analyses, which analyzed the survival rates of the placebo and treated arms of several randomized controlled trials. Taking the high prevalence of hepatitis virus co-infection, hepatocellular carcinoma has a relevant incidence in persons living with HIV. Our group, together with the Spanish group, described epidemiological features, clinical presentation, and outcome of hepatocellular carcinoma since from 2004. If we look at the data of HIV-CV co-infected cohorts in the last years, a constant increase in the incidence of hepatocellular carcinoma has been observed, even if there was a decrease of other liver events, probably as the consequence of the availability of anti-HCV antiviral. The incidence of hepatocellular carcinoma is higher in patients with cirrhosis, as expected, and higher in patients with CD4 lower than 350. However, in patients with cirrhosis and CD4 higher than 350, the incidence of hepatocellular carcinoma is almost similar to the incidence of other liver events. However, age and cirrhosis are the most important predictors of the occurrence of hepatocellular carcinoma. In the next few minutes, I will try to summarize the major issues in the management of HCC, the diagnostic algorithms, the therapeutic options, and the therapeutic algorithm. We will start from diagnostic algorithm. Typical hepatocellular carcinoma can be diagnosed by imaging, regardless of its size. It is a typical vascular pattern, and Asian-Pacific guidelines underline the key role of imaging in the diagnosis of hepatocellular carcinoma. The observation of the typical vascular pattern is the hallmark of HCC. MRI is the most sensitive technique. However, a typical pattern could be seen. The nodule and the lesion occupying space in a non-cirrhotic liver should be managed with a guided liver biopsy. The EASL guidelines report a clear diagnostic algorithm for the management of a nodule identified by ultrasound in a cirrhotic liver. A lesion of less than 1 centimeter should be re-evaluated after 4 months. A lesion greater than 1 centimeter should be evaluated with a contrast-enhanced ultrasound, with or with a CT scan, and with MRI. Even if a single technique demonstrates a typical pattern, the diagnosis is confirmed. If the imaging is not clear, a liver biopsy is recommended. Patients with a diagnosis of HCC are staged according to liver function, defined according to Child-Pugh classification, size and number of lesions, vascular invasions, and performance status. We can consider a very early stage or stage 0 in a patient with a Child-Pugh A with a single nodule of less than 2 centimeters. An early stage in a patient with a single nodule or 2 or 3 nodules with a diameter of less than 3 centimeters. An intermediate stage in a patient with multinodular hepatocellular carcinoma. Advanced stage in a patient with portal vein invasion or with metastasis. And in patient with Child-Pugh C, we have a terminal stage independently from the tumor sites, the presence of metastasis or vascular invasion. Then we can see which are the therapeutic options, starting from curative treatment. Surgical resection allows to obtain good results in terms of survival in patients without portal hypertension, liver dysfunction. In this case, a survival of 60–70% at 5 years could be reached. However, a negative issue is the high rate of recurrence in the remaining liver, around 70% at 5 years and 50% at 3 years. However, it is possible to push the envelope, reducing the risk of post-surgery decompensation, taking into account the size of resection, the presence of portal pressure, and the liver dysfunction, measured by the MELD score. So, minor resection could be performed even in patients with portal decompensation and with a MELD score greater than 9. However, the best results are obtained in patients with a MELD score less than 9 and with a portal, without portal hypertension. Percutaneous ablation of the tumor can be pursued by different techniques. Ethanol injection is a second-line, effective but very cheap and easy way to destroy the tumor tissue. First-line techniques are radiofrequency microwave ablation, cryoablation, and electroporation. Each technique has its advantage and its limitations, and the choice could also be tailored according to tumor size and site. The efficacy of ablation therapy is related to the size and site of the tumor and offers a 5-year survival in the best case of 40–50%, slightly lower than the surgical resection, even if the range of candidates is definitely larger. It could be done also in patients with liver decompensation. It could be done also in patients with portal hypertension. Also with this technique, however, the recurrence rate is high, 50% at 3 years and 70% at 5 years in the remaining liver tissue. Liver transplantation offers the best results in terms of survival. However, patients should be selected according to the absence of metastasis and vascular invasion, the size and the number of the nodules, defined by the so-called Metro ticket. Downstaging of the lesions with other technique is evaluated currently in order to increase the amount of candidates, taking also into account the reduction of the waiting list related to the lower occurrence of decompensation in patients with viral hepatitis that is also related to the use of antivirals. Now we can move to the non-curative treatment. Transcatheter arterial therapy joins selective arterial embolization in the tumor tissue with the local administration of chemotherapeutics, which can also be bound to eluting beads in order to reduce the systemic activity of these toxic drugs, or we can use radioactive particles. The selectivity of embolization is the key factor in order to spare the non-tumoral liver tissue. Transcatheter arterial chemoembolization should not be used in patients with decompensated liver disease, with advanced kidney dysfunction, with macroscopic vascular invasion, and with extrahepatic spread. Radioembolization has a very high cost, and general selection criteria are still to be defined. It has been investigated as a bridging to transplantation in patients with stage B tumor, comparing it to transarterial chemoembolization, in patients with advanced tumor, comparing it to sorafenib. Current data show a good safety profile and tumor control, but fail to show overall survival benefit compared to systemic therapy. Since from 2005 and 2008, we have targeted therapies for hepatocellular carcinoma. We have a series of antibodies acting by inhibiting growth factor, acting by binding to the receptor. We also have a series of small molecules acting on the post-signaling of these pathways. In addition, we have drugs able to reactivate the immune response against tumors, acting on PD-1 and CTLA-4. We have first-line systemic therapy with 2 small molecules, sorafenib and lenvatinib, acting on growth pathway, and a combination of 2 drugs acting on both growth factor and immune pathway. In addition, we have plenty of second-line therapies, including both classes of drugs. These therapies could be tailored according to genotypical and phenotypical tumor patterns, which can also break the dichotomy between first and second-line therapy with a precision medicine approach. And this approach seems to be promising for HCC, as it is now the standard of care for other tumors. Unfortunately, we have increased with this drug the spectrum of adverse events, adding those induced by immune modulation to those related to growth factor inhibition in other organs. Which is the role of antiviral therapy? Liver decompensation is the key contraindication to these systemic therapies. And if liver decompensation occurs after treatment and after progression of liver tumors, there is no space for a second or a third line of treatment. If there is tumor progression and the liver is still compensated, there is a space also for second line and third line therapy. Liver decompensation is also the main driver of death in HCV-infected patients treated with curative treatment. And you can see here that the rate of death is related more to early hepatic decompensation than to early recurrence in case of surgical resection or thermal ablation. And HCV eradication by antiviral drug is a key factor in order to increase the survival in patients with hepatocellular carcinoma. Taking into account the heterogeneity of therapeutic options, each case of HCC should be discussed and managed by a multidisciplinary team, including an oncologist, a radiologist, a surgeon, a liver transplant expert, a pathologist, and an hepatologist. Now we will see which is the therapeutic algorithm. That is very simple. BCLC classification indicates also the therapeutic algorithm, where resection, ablation are the main treatment for early stage hepatocellular carcinoma. And in patients with intermediate stage, transarterial catheter therapies are the best, also in case of recurrence after curative treatment. And in patients with advanced stage, first line and second line systemic therapy as the best choice. In patients with Child-Pugh-C, with the compensation, there is only space for the best supportive care. However, even in patients with early hepatocellular carcinoma, the site and the size of the lesion dictates the use in some cases of transarterial catheter therapy, which could also be the choice in patients with early hepatocellular carcinoma. Following resection or ablation, or before these procedures, there are no enough data to support the use of systemic therapies as neoadjuvant therapies according to both European and American guidelines. However, there are several ongoing trials trying to demonstrate the benefit of systemic therapies after curative treatment, and a series of trials trying to demonstrate the benefit of the combination of systemic therapies with transcatheter arterial treatments in intermediate stage. In conclusion, hepatocellular carcinoma has a high mortality, but is an heterogeneous cancer with high prognosis. Diagnosis is based on imaging and cirrhosis and biopsy in non-cirrhotic liver. Staging is defined according to liver function, number and size of nodules, vascular invasion, metastasis, and performance status. There are several therapeutic options, and these dictate the management of each case by a multidisciplinary team. We have curative treatments such as surgical resection and ablation with good survival, but with a high rate of recurrence in the remaining liver. And transplantation is the best option, but is the most challenging. Non-curative therapy now cover a wide range of treatment, starting from the old style transcatheter arterial therapy to the new kid on the block systemic therapy. Antiviral therapy plays a pivotal role because viral eradication and suppression reduce the evolution toward the compensation that is the main cause of treatment interruption. The timing and indication of each therapeutic option is suggested by the disease stage according to BCLC classification. However, mix and match strategies combining different therapeutic options are the next perspective that, however, should be pursued only randomized controlled trial. Finally, I wish to thank Professor Antonio Craxi of University of Palermo, which has given many useful suggestions for this presentation, and our Niguarda HCC multidisciplinary team, and you for your attention.